Hi, I'm Nicole Protopis, and I'm the Executive Director at Unravel Pediatric Cancer Foundation. We are kicking off a new series called Simple Science, and this is to help bring knowledge and awareness around projects we either funded or current events to help our donors and warrior families be more connected. Today, we have Dr. Steve Pergam with us. And Steve just told me he was going to be on NPR in like 45 minutes, you guys. So I'm feeling very humbled by the fact that Steve has joined us today. The reason I asked Steve to join us is, as many as you know, I worked at the Fred Hutchinson Cancer Research Center, and I had the great opportunity to work with Steve Pergam. He's a fantastic person. Steve is the medical director of infectious disease prevention at the Seattle Cancer Care Alliance, and he's also an associate member of the faculty at the Fred Hutchinson Cancer Research Center as a researcher. His work really focuses on vaccines, infectious disease, and microbiome. And I thought that what he has to share with us about what's happening with COVID-19 and how we all can be prepared would be tremendously insightful for our warrior families and donors. Steve, thanks for joining us today.
Well, it's my pleasure. As you know, I'm always happy to talk to cancer patients and families. It's really important to me. And you know this, I'm a cancer survivor myself, and so I think it's an important piece to educate our community however we can. So I'm happy to be here. And thanks for inviting me. Too many nice things to say, please. I'm more humble than that, but appreciate it.
That's what you guys need to see, is that Steve it's almost painful to compliment Steve because he's so humble. But one of the things that Steve always did when it came to cold and flu season to help protect cancer patients and the caregivers that were so crucial in helping them progress through their cancer treatment journey is he put together some procedures and protocols within the Seattle Cancer Care Alliance. I'm assuming, Steve, you've done that same thing with this COVID-19, if not stepped it up a bit.
Yeah.
So can you talk a little bit about what you've done to make sure that the practitioners at the Seattle Cancer Care Alliance stay healthy and the cancer patients? And then how has that translated into maybe other cancer institutions or hospitals around the country adopting some of the things you've set in place?
Yeah, so we've always been really focused on prevention as a key piece. So for a long time, we've had respiratory prevention strategies that anybody who comes in the door is screened for respiratory symptoms. If they do, they're given a mask. And depending on the population, they're tested to make sure they don't have flu or parainfluenza, one of the other respiratory viruses that's typical during respiratory virus season. There's tons of hand hygiene stations around. We do lots of education to get people flu vaccine. We give away free flu vaccines to caregivers. We're really just focused on trying to prevent this from happening at all. So it's been a really robust process in the sense that anyone who comes in is asked questions, whether it's a caregiver, whether it's a patient. And then for staff, every year, there's a really a robust process to get them engaged so that they don't come in to work sick, because we really want that not to happen. And so for patients in general, we also sticker them. So we put a sticker on that says "I've been screened" to allow people as they walk through the center to know they've been screened at the front door. It also allows us to change that sticker depending on the color, whether they need flu vaccine, whether they need to be tested, et cetera. It can really help us manage that process. So as it was already flu season and already respiratory virus season, we were already doing that as a routine. And I think that helped us a little bit to help prevent this new organism from getting into most of our patients. What we've now done is we've shifted it so they're actually at the front door. So you're not allowed to walk into the center without being screened. So that screening has changed. There's new questions we're asking that are related to the virus. And so anyone who comes in the door, there's one entry point. Everyone has to be screened coming in that door. And anyone with symptoms is sent to a secondary screener who then asks additional questions and will actually swab them right at the door to determine if they're positive or not. Those who have really more prominent symptoms, we try to talk to the teams and see if we can rearrange their visits. If not, then we mask them with really clear directions. We try to limit the amount of time they spend in the clinic. So a lot of rearranging if possible. And in general, if we're concerned, they'll call us and we'll talk with the patients and see if we can shift them to another time. So I think that's really helped a lot in getting people to feel more comfortable, because we've really got an active approach up in front, and basically we're doing, probably 40 swabs every day for people that have symptoms walking in the door, and that's helping us to sort of see what community levels are, which is helpful. It also allows us to protect our employees by identifying people with symptoms really quickly, masking them. So that masking process helps to prevent respiratory droplets. And then those people are then seen in droplet precautions, which means you're wearing a mask with a face shield, a gown, and gloves, and really try to limit the number of people who actually go in to see the patients if possible. But one of the things that's been helpful is we've been able to shift some appointments. So we do a lot of pre-reviews of patients that are coming in to try to identify who needs to be there. So we'll figure out if it's a follow-up visit that's not critical. We'll talk to the patients and families and say, "What do we put this off? Not critical." There's a lot of survivorship programs and things like that that have been sort of sunsetted for the moment because they're not critical, and we can do a lot of those visits by telehealth. So we've switched a lot to conversations with patients on the computer, which isn't necessarily as personal, but in a situation like this is really helpful. So that, I think, has been some of the early work that we've done in terms of figuring out ways to keep them out of the clinic.
Again, are other hospitals doing this same thing? Screening out? It's kind of standard practice now?
It's become pretty standard now. I mean, I think many of the centers that are having this are really, they're really trying to avoid sick patients coming in. And if they do, they're trying to mask them because that's the best approach to sort of protect everybody. It's really challenging. I mean,
absolutely.
There's a lot of patients who come in who have chronic symptoms. People with head and neck cancers, as an example, they're often having cough, or lung cancer patients. How do you sort it out? How do you sort out what's what? It gets really challenging, but we're being really aggressive about our screening because we want to try to not miss anybody. Because the idea of identifying someone and treating them in precautions helps to protect our staff. And it also helps to protect a major spread within an institution. So that's really key.
So one of the things that I think is interesting is it feels like, obviously I've been listening to a lot of town halls, the Fred Hutch town halls, and watching the news and kind of trying to be aware of what's going on. But it feels a little conflicting is in terms of the even PSA ads that we see coming out from, I'm guessing the government, NIH maybe produced them to say, if you're 60 plus, if you have any kind of comorbidities, but then you read a story and it says this person died and they were 40 years old and they didn't have any other issues or symptoms, and it went really fast. And then there's other people, they say, well, they tested positive and they had basically a runny nose. So I'm kind of curious to talk it, because not as much we know our cancer, the cancer patients, the children, because they're in treatment, are going to have some level of immune issues. And then we also know, based on what I've read, that came out from the Hutch, is that transplant patients are probably the most vulnerable in the cancer patient population. But what about the caregivers? Like, talk to me a little bit about, because at first I was thinking, oh, you have to have a fever and you have to have a cough and you have to have a runny nose, but that's not necessarily the case, right?
Yeah, I mean, the symptoms can be pretty varied. And for normal, healthy people, particularly younger parents, it can be really hard. They may have, a little bit of a cough, a little tickle in their throat. It can be a sore throat. You might have sort of general muscle aches and sort of fatigue. You might have headache. There's been some abdominal symptoms. You can have some diarrhea, as an example, that can be associated. And it's like sort of everything, right? It's like
Yeah.
very difficult to sort through. One thing that's been interesting that's come up in the last few weeks has been this loss of smell. Has been one
I
that's been
saw
really
that.
interesting.
Yeah.
We've seen that a couple of times now. So I think it's any of these are possibilities. So what I generally tell people is, if you have a patient if you're a caregiver and you have a patient with cancer, the biggest thing you can do is really practice social distancing. Um, I'm not sure social distancing is the right term. It's like stay away from other people.
Yeah.
um, but
It's
it's
just
not.
real
It's not.
distancing.
Yeah,
Just
it's
keep
real
away.
distancing. It's just be
Yeah.
6 feet away from people, and you can do that. I've been doing it for a while. The challenge for caregivers is they have to take care of their kids, which means they have
Yeah.
to take them to appointments. They've got to go to the grocery store. They've got to go to the pharmacy to pick things up. There's a lot of activities that can happen. So it's all about planning. And it's also realizing that none of us are perfect. And that, with a virus that's super contagious and has the ability to infect people, because none of us have pre-existing immunity, it's going to be one of those things that even our best practices occasionally don't work. And so what I suggest to families is, if you have two people in the household, it gets easier because you have a family member who you can say, you're the person that's the go-to that go gets things. The other person stays at home.
Yeah.
And then if that person who is not staying at home, the person who's going out, starts to develop any symptoms, just, if you can, try to separate them from the individual who's ill and potentially the person who is otherwise healthy. And then, as best you can, if you have a second bathroom, you can use that. If you don't, make sure you wipe down the seat and other things like that as best as possible. We don't really think it's a major transmission pattern, but we're just trying to think of any solutions there. And then use lots of hand gel or washing your hands between episodes. I've known some people that have sort of had a family member that they put them in a bedroom, and
Yeah.
the other person sleeps on the couch. And they take care of the younger one until they get symptoms. And then the key piece is just having some discussions with your team. So call ahead to your cancer team and say, hey, one of us might have symptoms that might be consistent. What would you recommend? And they can sometimes decide they want to bring the child in to do testing. They may want to bring other parents in there. There's opportunities to do that in some institutions. And they can also advise you where in the community there might be testing available, because that's becoming more widely available in certain areas. So if there's opportunities, you can. It's harder because most of the time, if you don't have major symptoms, they don't want you coming in for testing. So
Yeah.
it's this balance between the two. So it's hard to know the perfect solution. And we do think that home transmission is probably the most, because you're so close to each other, it's the biggest risk. So
Well, it's interesting to me because right now, what
mhm.
people we're doing, we're ordering groceries. We
Yeah,
might be
sure. Yeah.
getting them delivered. People are picking those out for us. They're touching the
Sure.
food that we're
Yeah.
about to bring into our home.
Yeah.
So even that piece of it, it's hand washing is, we all know hand washing, right? We
You'd be
all know.
surprised. Yes, but I know what you mean. I know what you mean. I
Well,
mean,
by
I think
this
so.
time, if you didn't know it before, you
Yeah.
certainly do now.
Well, so maybe
But
maybe I could explain sort of what I do with my parents.
yes.
My parents
Yeah.
are older, and
Yeah.
so first of all, I read them the riot act. They were not allowed to leave the house. Uh, so what
They
they do
don't
is
like to hear
they go
that.
they go outside. They go outside to walk. They walk their dog,
Yeah.
which is great, and they choose a side where there's less people walking by. When
Yeah.
people do walk by, they try to move to the
Across the
side to
street.
have
Mm-hmm.
some space. Right now, they live in an apartment complex, and so
Mm.
when they get in the elevator, um, if there's someone else in the elevator, they just wait to go down.
Mm-hmm.
They use their knuckle to push the
Yeah.
button. They wash their hands on a regular basis, and they are getting grocery deliveries and things like that. And so what I tell them typically is just bring them in, put them have a place in the house where you have like a little you put all the groceries. take everything out of the bag, put it away. And then if you wait, 24 hours before you eat something that you brought from the grocery store, it's usually going to be fine. And then you just wash your hands really well if you put things away. When I get food from delivery, when I get it, we just put it in the microwave for 30 seconds after we get it, just to kind of another way, and then try to take it out of the container and put it into something else. Normally, eating is not going to be a primary, it's not a way that you're going to get it. So if food is contaminated, it's not a risk. It's the touching of the container. So always when you're touching something that's out and you're putting things away, it's a matter of just, washing your hands again after you do that. My wife describes this in a funny way. When you're making meatballs, and your hands just have, meat around them. She calls them meat hands, and we've been joking about this. It's kind of crazy, but if you think about it, when you go outside, you think, okay, this hand has now been contaminated.
Yes.
And so you want to make sure you're not touching your face or, licking your finger to go through your mail, things like that. You can really, there's just easy ways to stop yourself. And so you say, when you walk outside, when you touch something outside the house, it becomes something that you should be thinking it's contaminated. And that contaminated hand then needs to be washed before you're allowed to touch anything else.
Wow.
So I usually, sort of cross my hands like this. I'll walk in the house and I'll do stuff. I mean, again, you can't be perfect, guys. It's an impossibility.
Yeah.
But there are definitely steps that can help. And so
I think this is really interesting of you saying, put your groceries away if you don't touch them for 24 hours, because there is different information out there about how long the virus actually lives on certain surfaces. And that's really interesting. I also love, I want to support small businesses, restaurants out there. So getting takeout, and I was thinking, are we exposing ourselves to when it's
think about it, like,
takeout?
if you look at like Uber Eats as an example, now has an option that they can leave it on your front porch. So we text them ahead of time and say, leave it on this area. And then I go out and pick it up. I put it on a place on the floor. I take out the materials. I bring it all. We do that quick microwave, and then we eat it. It's the reality. I mean, that's not likely to be a major risk. And more often, the people that are working are not actually symptomatic. Sometimes they'll say, don't worry, I always wash my hands before I pick up stuff. There's a lot of discussion about this, and grocery stores generally are not packed at the moment. So anybody who's going in to pick up supplies for you isn't necessarily in a situation that there is likely lots of touching. Normally in our lives, we go out and pick up fruit. We look at something, and we're like, I don't know if I want that one. You put it back. I wash everything we get, even, apples and oranges. I just wash the outside really quick. Yep.
So I did listen to the recent town hall that featured the new director, new
Tom
president
Lynch.
of Fred Hutch, Tom Lynch, and Nancy Davidson and Julie McElrath was on there as well. And when I say that, just for our listeners, everyone in Seattle, when I name these names, they're all really very prestigious doctors. And in any other place that I have worked, I would call them Dr. such and such. But in Seattle, nobody likes to be called doctor. They go by their first name. So it's very strange if you were ever told you had to call someone Mr. and Mrs. such and such. It's a new world out here in Seattle. But what struck me a little bit is when Julie McElrath talked a little bit about and the time it would take to develop a potential vaccine for COVID. They were talking about anywhere between 12 and 18 months. And immediately when I heard that, I thought, oh my gosh, we could be dealing with this for so long. And then I thought, well, that's interesting. There's a difference really in treating the virus versus us creating an immune response to the virus by creating a vaccine. So can you talk a little bit about how the healthcare workers are trying to treat the symptoms of the virus in order for people to survive the virus, and then what the vaccine will be able to do?
Yeah. So treatment's really challenging. because there's not a lot of data at the moment. An example is there was a drug called Kaletra, which is an HIV drug that was used and looked good in vitro, and had some potential benefits. People were buying it up, and people were talking about giving prophylaxis to healthcare workers and all kinds of stuff. And then the initial data from China showed no benefit, and so it was dropped. So the problem is there's a lot of things with new viruses that look really good in a test tube, but don't actually work in real life. So right now, the one that many have heard is hydroxychloroquine or Plaquenil, which is a drug typically used for lupus or a disease called rheumatoid arthritis.
Yeah.
And there's a big trial at University of Minnesota that's being done in patients that have been either exposed or potentially have just been diagnosed with the disease, that hopefully will help us to understand how much that helps in a normal person. But we're trying it in other groups at the moment, but hard to know if it's going to be effective or not. I'm suspicious it won't be. It's been used or been posited as a possible antiviral in other viruses and hasn't worked out in real life where it looks good in the lab. There is a study looking at Plaquenil and a drug called azithromycin, or some people might know it as Z-Pak, right? And that combination seemed to potentially be maybe a little bit more beneficial, but that study was only 30 patients, so that's in the shoes. But was done by a world expert, Didier Raoult from France. And so I don't know, I'm not sure what that's going to look like. I think some people are trying it. Again, these are all attempts. So we're trying these different things. The one that I think is most exciting is there's a drug called remdesivir, which is made by Gilead. And it was initially, I think they tried it in Ebola at some point, and it wasn't super effective, but it's a better agent. It looks like a better agent for coronavirus. And so there is an NIH-sponsored randomized clinical trial that's being done here and many other places that's looking at that drug as a potential. And so you have to be in the hospital on oxygen to be able to get it, but that's been one that has been enrolling very quickly. My expectation is that that trial will be done relatively soon, and we'll have some early data to suggest whether it's beneficial or not. My hope is that that would be one drug that would be available. The problem is it's IV, so it's not really easy to give as an outpatient version, which is unfortunate. But to have another agent for really sick patients would be really wonderful. I'm not sure how quickly they can ramp up production. That's a whole other thing.
Yeah.
So in terms of the vaccine, so obviously Julie's much smarter about vaccine production and how to get a vaccine on the market. I mean, a year is super
fast.
Super fast.
Yeah, that's super fast.
I think that's unlikely to be the case. There's a lot of rigorous levels that a vaccine has to be reviewed.
Yeah.
It has to go through multiple different trials for safety and efficacy. It has to have a large group of people who get vaccinated. It's very challenging. My inclination to believe that there's going to be a vaccine available is, a year and a half at best, if we get lucky. If we really,
but that doesn't mean that we wouldn't create our own immune response.
Yeah, that's right. So if you get infected, you could get an appropriate immune response. The hard part is for cancer patients.
Yeah, absolutely.
Is if there is a vaccine that's effective for the general public, generally for our cancer population, if you get vaccinated, you don't have as good of a response. We know this with measles, we know this with influenza vaccines and others, that unfortunately, even in a perfect scenario, if we had a vaccine that was available, we could give it to you, but probably you would not be as affected by that and not as protected. I think a lot of the things we're doing now, like the social distancing, washing hands, being cautious where you go, not going to public places. These are all the advice I give during normal seasons, because I know that even in a best case scenario, if you've had the flu vaccine, you're probably not super protected. So I think that probably doesn't change. But what would be really helpful if you had a vaccine is to vaccinate caregivers and the people around that person. So those in close contact could be protected and would be less likely to transmit it to the individual. So that's really where vaccines are helpful. Those that are high risk, you can do sort of this, what's called a ring vaccination, where you vaccinate everyone who's close contact. And by doing that, you can protect people. And frankly, vaccines are critical because if you can increase herd immunity, this idea of, getting more of the community protected from this, then it's harder to transmit. So one person who has it, they try to pass it on to somebody who's already been vaccinated, they don't get it. And so that transmission pattern dies off. And so vaccines really help decrease the number of events that happen. So an example that I was giving that gave to somebody else is, we often look at something called R naught, which is this: how many people do you infect? Is a simple way to think about this. So an R naught of 3 would mean that if I was ill, I would give it to 3 people. Okay. If you think about 10 generations of giving R naught, 10 generations, I give it to 3 people, those 3 people give it to 3 people, etc. That means one person in that situation can cause 59,000 infections.
Oh my gosh.
Yeah. So an R naught of 2, you get about 1,000.
Yeah.
But every single time during each of those transmission chains, if you have more herd immunity in a situation like this, where there are more people who are protected, each of those transmission events drops. And it's really amazing when you think if you had, one of those people drop off, instead of 59,000, you'd have 1,000 patients. If you drop that R naught to 1.5, meaning that other people are protected and you can't transmit, then it's much less. In influenza, which has an R naught of about 1.4, because of influenza vaccine and other things, we can drop it even lower. In a perfect scenario, 10 to 10, it means 14 patients you'd expose over 10 generations, which is much different. So I think anytime you can increase the immune status of those in the community and protect many other people, get more people vaccinated, you can really decrease the risk of each of these transmission events leading back to a patient who's really at risk for developing severe disease. It's the best way to think about it.
Wow. That was hugely insightful, because I hadn't thought about that. I think we've been talking a lot about how COVID has multiplied, but we haven't used it in the context of the example you just shared, which is super powerful. I mean, we have a family of 4 in this household right now. So the impact of us being outside and how that would multiply, that was a great example.
Yeah,
Thank you.
I think that's part of the reason we talk a lot about social distancing, is that, if you don't get it, everywhere along that chain of 59,000 infections, the less people are interacting, the more those chains die, and the less overall happens. And there's some really good infographics that people have put together looking at that. They can show you how much of an impact you can make as an individual. And so I think it's really critical to move in that direction if you can, because if you can't do that, then it does spread really quickly. So, if you all decide to go to spring break and hang out at spring break, as they did in Florida.
Steve,
no.
No.
I mean, there was a really interesting, they followed cell phone images. They looked at cell phones and they tracked cell phones about where all these kids went to spring break and where they traveled around the country. And it's really terrifying. You think if there was a lot of spread in that situation, where they brought those infections back. And in the modern era, when we're getting on planes and we're driving and we're traveling much more, it's really easy for these things to spread. And you can see that in the United States.
Well,
we've had a bunch of places where this has been popping up, and any place that's testing is fine again.
Yeah, that's where we're seeing. I want to ask one more question, and then I have some questions from people that sent in, and I want to make sure we get to those.
Sure, no problem.
But when we talked about cold and flu season, years ago, H1N1 came out, and I haven't really heard anything about that. So my curiosity is that Dr. Lynch, the new director of Fred Hutch, had kind of brought up this whole thing of, we are going to find cures or better treatments for cancer that could be curative therapies. Viruses are always going to be around. And it was a very, it's true. It's absolutely true. And I thought about H1N1 and I thought, wow, that's interesting. Is that now part of the cyclical flu vaccine? And will whatever comes up of COVID be included in this new? So we won't talk about COVID anymore. We'll say it's just cold and flu season again, and COVID's part of it. Yeah.
So, I mean, it may be that there's more there will be more pre-existing immunity in our communities as this spreads.
Yeah.
So that's one thing we think there's many who think this will be a seasonal vaccine, I mean, a seasonal infection that then is with us for a while. So we have four major strains of coronavirus that are human coronaviruses that are commonly spread every season, where they're minor URI symptoms you do fine. No one really gets severe disease. It could be that COVID is, part of that group, and that over time it becomes less prominent as a complication. As we have more immunity to it, we have better ways to treat it. We have better prevention. I don't know, but my
It's just,
assumption is yes. My assumption
yeah.
is that it's probably going to be something that's going to continue for a while. There's enough of it around.
Yeah.
There's enough of it in different places in the world as it sprouts up. One of the concerns from China at the moment is they don't have as many cases, but they're worried about importing it now because it's coming from other places where it is. So that'll be the issue, is that wherever it's going, it's going to slowly go across the world, and it'll be someplace.
Yeah.
And probably it'll be my guess is it'll be a seasonal pattern, but we don't know. That's a big unanswered question for us.
It's interesting. So,
Yep.
so the Unravel family, some of the members
Yeah, sure.
sent in some questions I just
Sure.
want to ask, and
Yeah.
one's pretty pertinent.
Yeah.
The limited access to the N95 masks. I mean, these are crucial for patients and their family. They can't get to them.
Mm-hmm.
The CDC had said homemade masks are suitable backup
Yeah.
if there are no medical grade masks can be found. Do you
Mm-hmm.
agree with that?
Yeah, I mean, so I think about it. So first of all, N95s for the general public are probably not super helpful. And it
Yeah.
sounds kind of strange, but you really need to be fit tested to have a mask that fits you. And most people have never been fit tested. So those N95s are really important for healthcare workers on the front line, because there's a lot of people who don't have, who we're really struggling to keep those in
Yeah.
hospital systems. We're having to reuse them. It's been a real struggle. And so we're not recommending those for the general public. Even surgical masks we're not sure how much they help. But I think in general, what I tell people is social distancing is first. That's important. But if you have something that I mean, there's lots of people that are making like little cloth masks or
Yeah.
things like that you can wear. You can put one on. They're probably not super effective. What they are effective at is really preventing you from infecting others. And I figure they're better than zero. So most of
Yeah.
the studies that have looked at them have not shown much effect, but they've been compared to other types of masks. But when you compare them to placebo or no mask at all, I think there's probably some minor benefit. So I would definitely think it's not a big deal, and go for it.
Yeah.
Yeah.
So another person had wrote in and said, why is this virus so dangerous? Meaning, like, what's happening that's making this virus so dangerous?
So COVID's really interesting. It's a virus that, first of all, none of us have ever seen before. It's an animal to human transmission. Similar to what we think about in these novel pandemic flus, is there's been a reassortment. This is actually a novel virus that nobody has prevention, and nobody's had access to before. And so when it spreads, it can spread very easily. When 100% of the population has not seen it, everybody can become
Yeah.
infected.
Yeah.
There seems to be people with low-level symptoms who can spread very easily. There's even some thought that there can be some asymptomatic spread. And so if that's true, it's harder to control unless you separate people. What it does to people is really interesting, because it has, coronavirus is similar to SARS, which was years ago. It was this another coronavirus that's been similar. It has a receptor, the ACE2 receptor, which is primarily in the lung, but in other organs. And so by connecting in those areas, it causes an overwhelming, what we would call an acute respiratory distress syndrome, or an acute inflammation in the lung that can lead to really difficulty breathing, and the need for ICU admission. What's interesting about COVID, it doesn't really do this in the younger group, and we can talk about that in a minute based on another point you made earlier. But it's really focused on older patients. People in their 70s and 80s are the ones who are getting the sickest and the ones that are dying from their disease. and then immunosuppressed patients. There's been at least a couple of reports of children with immunosuppression that develop more complications, but even they may be somewhat better. But in general, we worry about people who are the most vulnerable. So immunosuppressed patients, people with chronic illnesses, people with lung disease and heart disease, kidney disease, and then those who are older. So it seems to really target the people that are the most vulnerable in our communities. And what it does is it can overwhelm the healthcare system, because as large groups of these people get sick and show up at the hospital and need care, there's a lot of people that need oxygen, a lot that develop pneumonia that need hospitalization. There's a lot of people who need to be in the ICU, and a lot of people who need to be put on a ventilator and that breathing machine. And that stretches the system substantially. And by stretching the system, it's also stretching resources. So when people worry about not having enough ventilators to protect patients, that's important. Not having enough masks to protect providers. Just the hospitals have had to redeploy things in very different ways. There are some places that are building, mini tents to take care of patients in front of hospitals. There's some hospitals that have been shifted towards COVID specifically. We're all creating COVID specific units in different locations because of that worry. And I'm sure you've seen information from New York and other places where it can be quite overwhelming.
Yeah.
It doesn't look that bad on the street, but the physicians will say they walk up and it's super quiet on the street, and then they walk up to the hospital and it's just pandemonium. And so I think that's really what's hard, is that, in general, people would say, oh, it's not that bad. It's 1.5% of the population that's going to get really sick, or 1.3 or whatever. But if all of us, or a lot of us, get this, and 20% of us, 15% of us, 10% of us need to go to the hospitals, it'll overwhelm the hospitals. And if 1% of us get sick enough to go to the ICU, then that's going to overwhelm the ICUs.
Yeah.
And so that's one of the reasons we're really trying to prevent transmission, is to slow this process down. You've heard this idea of flattening the curve.
Yeah.
We want to take the curve and squish it down. Probably means the same number of people get infected, but it just stretches it out so the hospital systems can manage it much more easily, rather than having to deal with a major influx of patients at one specific time.
So are you thinking that even the children with cancer that are currently in treatment right now are faring better than the adults?
Hard to say. There's been some reports that maybe the outcomes are a little better in children. There's been some outcomes that are not so good.
Yeah.
In really sick kids that have really bad immune systems, but we just don't know. We just haven't seen enough. So in general, kids are not as sick. That's one thing that's clear. What's interesting is, you asked earlier, you've seen these reports of really young people having complications. It's sort of law of statistics, right? I mean, it's generally more 40-year-olds and 30-year-olds get infected. There's going to be a few people who are going to get really sick.
And those are the ones that they're putting out in the media.
Those are the ones that you're seeing on the news and you're hearing about. What you're not hearing about is the fact that 50% of all deaths in the state of Washington are people over 80.
Okay.
So it's really an older and a disease that really affects the elderly much more. I think the younger patient population is scarier, and it really is where you're inciting a lot of fear when you hear that an 18-year-old died or a 20-year-old died. But those are really infrequent, and the majority of disease that we're seeing in patients is older. As there is more in the community, so as you see more and more spread in the community, you will see more 30-year-old and 40-year-old and 50-year-olds because of the total numbers.
Yeah.
So more will end up at the hospital in those situations. But in general, that the majority of the disease that we're seeing in the real severe cases are in the older population.
So I've taken up a ton of your time, and part of it's just because I love you so much, and it's always good to talk to you, Steve. But one last thing to ask you is, before we wrap, is just to say, when people are looking for the most reliable resources to get their information, because we're just getting inundated. I mean, we're almost overwhelmed by it at this point. What should we be paying attention to? What resources?
Yeah, so I recommend most people go to their Department of Health or their local public health websites. They can be really advantageous because they'll give you local numbers of what's going on. They'll give you patient information sheets. They'll link you to other websites that are important that can help engage you and help you think about what you're going to do next. They'll also tell you whether there's current outbreaks or concerns. Talk to your providers, talk to the hospital systems where you work and see what they can tell you about what's going on. Call ahead to your providers and get information. And then the CDC website's pretty decent. So there's quite a bit of data on there that can be really helpful. There are lots of others, but I'm really cautious about sending people in too many directions.
No, I
because
think
there's just so much.
There's so much. This is
Yeah.
super helpful.
Yeah.
Steve, I know you're
Mhm.
so busy right now.
To say the
And
least, yes.
I
Yeah.
thank you for spending so much time with us on
Of
behalf
course.
of
Yeah.
all of us at Unravel.
Sure.
You're
Couple
amazing.
things let me tell you a couple things just before we end. So I know it feels weird to be out and to not be out in public and to be staying at home, but it is really important, and all of us have a role. And I encourage all the families and those who are dealing with cancer to talk to friends and family and to spread that message as much as possible. You can do virtual dinners where you all eat together on video camera. Seems pretty dorky, but it works well. You can play board games. You can, watch movies. I've had friends that have been watching a movie. They all started at the same time and they talk through it so they can all watch it. There's lots of ways that you can sort of interact in novel ways. And I think this is going to be important because I don't think this is going to be something that's going to slow down for a while. If you ask me, I think it's going to be till, probably mid-June that we're in this sort of state. Unclear to know how long it'll last, but I do have some concerns that it'll be that long, so get used to it. And for patients, it's really important to stock up on your medication. So talk to your provider about getting your pharmacy to allow you to pick up 3 months of supply. And for some kids and some families, that's really expensive and they can't do it. Some maybe rare medications. So what I recommend is talking to your pharmacy, asking them to have it in stock for you, just so they have it in case there's shortages or things like that you can then pick up when you really need it. And then really importantly, if you feel sick, start to develop symptoms, talk to providers, get some advice, let them know that you live in the household of a cancer patient, or if you're a cancer patient, talk to your provider about the next steps. Sometimes the best thing to do is to not do anything, just to take care of yourself at home. And if they're really worried, they'll bring you in and evaluate you more. Find out where you can get tested in the community if you have symptoms, if possible, and that can be really helpful for taking the next steps. And if you feel sick enough, you need to go to the hospital because you feel like you're having shortness of breath, you've got really bad fever that's uncontrollable, and you really feel terrible. Call ahead to the ER and say, I'm a cancer patient, or I'm a member of a family that has a cancer patient, and I'm coming in with symptoms that I'm concerned about. I'm really not feeling well, and they can be ready to accept you there. And you can bring a mask, and if you don't have a mask, you can, as dorky as it sounds, you can wear a bandana or something else to help limit any secretions you have. And then just make sure you go right up, bring some hand sanitizer if you have it, and let them know that you have symptoms that are consistent with that. And they might triage you really quickly to be seen. But the biggest thing is just try to stay out of public places and wash your hands frequently. Follow the advice of your doctor and keep in communication if you have symptoms. That's the big things, I think.
Listen to Dr. Steve, people. He knows what he's talking about. This man, I think I'm going to nickname you the Germ Doctor. Is that okay?
There's plenty of people who have that name, I'm sure.
No.
Anyways, great to see you. And I'm really happy to be a part of this, and best of luck to everybody out there. I hope in the next few weeks that many of you stay healthy and safe. And as this goes by, we learn more about treatments. I think there's going to be a lot more information coming through the system. And please, if you are in the hospital system, take a moment to thank the people that are taking care of you. Many of them are on the front line, really, in some ways, putting their lives at risk to take care of all of us. And so it's really important that you take the moment to appreciate them. And that means the people who wipe the floors, the people who clean out the trash cans, the cafeteria workers, the people who check you in, everyone along those lines is spending time in the hospital so they can help protect all of us. So please take a moment to thank them for all that. And if you have masks and other things at home that you do not need, look at donations so you can give them to your local hospitals so they can help protect you when you do come in.
Thank you, Steve.
You
It
bet.
was great talking with you.
Yeah, good to see you.
Yeah, good to
Take
see
care
you too.
and stay
Bye.
healthy. Stay home.
Thank you.
All right. Bye-bye.